alaikum. I'm Dr. LUBNA from Gynae Unit 2. I think I've taken your classes before as well. So today we are going to discuss a different thing, which is safe motherhood. That means what initiatives we can take to save the mother and the baby during pregnancy and after the delivery. So if you define safe motherhood, it comprises of a series of initiatives, practices, protocols, and service delivery guidelines. Basically, this is a guideline which I'm going to tell you. It is designed to ensure that women receive high quality gynecological, family planning, prenatal delivery, and postpartum care in order to achieve an optimal health for the mother, fetus, and infant during pregnancy, childbirth, and postpartum. So this is basically a guideline which is going to tell us that how can we improve ourselves and how can we provide good quality care for the woman. So let's talk about epidemiology. Over 770 million population in Pakistan. So maternal mortality rate in Pakistan is 276 per 100,000 live birth, which is quite high. And maternal death is about 28,000 per year. Lifetime risk of maternal death in Pakistan is 1 in 31. So you can see how high it is. 30% births, only 30% of births is conducted by a skilled birth attendant. Rest of the births are being conducted by guys, by maybe unskilled nurses, maybe LHVs, but only 30% birth conducted by a skilled birth attendant. 35% is the contraceptive prevalence and 15% antenatal cover. That means only 15% of our population, they come to primary care, they come for the antenatal checkup. Neonatal death rate is 300,000 per year. Infant mortality rate is approximately 84 per 1,000. 500,000 babies still born or die in the first week of life, so it is very high. Coming towards the causes of maternal mortality, the most important and the most common cause is hemorrhage, bleeding. So the bleeding can be antepartum hemorrhage during pregnancy, or it can be postpartum bleeding. Number 2, sepsis, that is infection, because delivery is conducted at home, in villages, in setup where proper hygienic conditions are not good. So later on, the women, they come to us either with some infection, sometimes pus in the abdominal peritoneal cavity, or different type of sepsis. So sepsis is nowadays almost on top as the cause of maternal mortality. Number 3, hypertensive disorders such as eclampsia, antepartum eclampsia, and postpartum eclampsia, obstructed labor. That means a labor which has been conducted in some place where proper facilities are not available. Abortion, non-availability of healthcare facilities, social, cultural, and economic reasons. How to prevent maternal death? Now, what steps we should take to prevent these deaths, which can be preventable if we have the facilities available? The 5 steps which we should take: provide proper antenatal care. That means every woman should have antenatal care, whether she lives in a village, whether she lives far off, but she should have some antenatal care and antenatal booking. It should be conducted or supervised delivery in a clean, safe environment by a trained birth attendant. Even LHVs can conduct a delivery, but it should be done in a proper setup. Prevent prolonged labor. That means if the woman has been in labor, even the LHV or the guys, they are conducting deliveries and they found that there is some problem which they cannot cope. So early referral is very important. Even in those cases where the patient is bleeding, you can save mother by sending her for early referral for proper management. Provide emergency care promptly to a woman with postpartum bleeding. Again, early reference, such as suppose a woman has delivered and she has have heavy bleeding period, it should be identified early, and the patient, if the facilities is not available in that setup, early referral is very important, because by the time the patient are here at tertiary care center, they have bled so much, or they have come from so far, or they have taken so much time, the woman has already gone into DIC. Number 7, counsel couples on adopting contraception to avoid unnecessary pregnancies rather than taking resources to unsafe abortion. That means for every pregnancy where you think the patient has 3 children or 4 children, they should be advised regarding contraception during antenatal period, that after the delivery, these are the methods or these are the centers where they can go and they can ask for the contraception rather than going for unsafe abortion. What happens? They get pregnant every year and then they take advice from the eyes, or they go to different areas where unsafe abortion from miscarriages are being conducted. Then these women, they again come either with sepsis, or then later on they may go into secondary infertility and many other problems. So this should always be taught. The contraception should always be discussed with the woman during antenatal period. Now, interventions for safe motherhood. There, basically, we talk about 4 pillars of motherhood, safe motherhood. Number 1, essential obstetrics, clean delivery, antenatal care, family planning. So that means the woman should have equity, should have access to these areas, that means hospital, primary health care, basic maternity care. So primary health care clinics should be there in every area if you want to have a safe motherhood. Even it may be a small, but then patients can be referred to an area where the high-risk patient can be referred to tertiary care center. So these are the 4 pillars of safe motherhood: family planning, antenatal care, clean, safe delivery, and essential obstetrics. Now, regarding family planning, there are certain factors which is for selecting an appropriate contraceptive: women's age, parity, age, and sex of her children, couples' desire for further pregnancies, duration of birth spacing required, previous obstetric history, whether she's breastfeeding currently or not, menstrual history regarding heavy periods, associated medical complications, and couples' compliance. Now, if a woman, suppose, I give you an example, a woman is diabetic and she already has 3 children or 4 children, so we should always advise her regarding pregnancies, like contraception, which should be permanent. Or if a woman is suffering from cardiac disease, I think we had one patient in antenatal booking. She was a cardiac patient since years and she already had 3 children, and now this was a whole pregnancy. So I advise her that it's better to have some contraception in the form of permanent method, because her condition of heart is not that good that she should bear further pregnancies. I told her, if you will live, your children will be looked after. If the mother dies, in a way the children also dies. No one is there to take care of children if the mother dies. So we have to counsel the women when they come for the antenatal clinic, or if they have got certain high-risk factors, or even sometimes very young girls, they get married and they have pregnancies every year. So, and sometimes they end up in cesarean section. So sometimes we see a woman, she's just 25 years of age and has previous 4 cesarean sections. So think about these women, what complications they can have so early in their life. So birth spacing is also very important, even if they do not want to have some permanent method, in case even the family is complete. So you can tell her about birth spacing, you can advise her birth spacing. Family planning clinic is almost not everywhere. Even certain family planning women, they also visit houses as well, so that they can advise the woman about the birth spacing, about the temporary method of contraception. But just because of our myths, we still have no prevalence of family planning methods. So regarding antenatal care, our aim should be to prevent and early detection of problems of pregnancy at an early gestation age. That means, number one, identification of problem, then prevention or how to take care. And if in a setup where this problem or a patient of high risk, such as cardiac disease, diabetic, cannot be dealt, then she should be referred to a tertiary care center. During first visit, we do history, physical examination, and certain investigations such as blood test and urine, the basic tests such as the complete blood count, random blood sugar, and viral markers, urine analysis, and ultrasound pelvis. This is done on the first visit. So when you take history, you have to take history of the previous pregnancies, or you have to take about any family history of diabetes, heart problem, or any history in the patient, any previous history of some infection, some operation, such as TB, diabetes, or cardiac problem. All this has to be dealt on the first visit, and we make an antenatal card. And if she's at high risk or she has got some problem and comorbid, so that is mentioned on the first visit of the patient. Along with that, we start with the folic acid, which is very easily available, and iron and calcium supplements are advised. They advise diet as well. And of course, if a woman is having no problem, she should have a visit monthly or after 2 months in the beginning, but later on from 27 weeks onward, she should have monthly visit, and then 32, 34 weeks fortnightly, and when she's at term, weekly visits. So that depends upon the patient. If suppose she comes out to be diabetic, so we will call her early. If she has cardiac problem, we will call her early, and we will also tell her to visit the cardiologist. We will tell her to visit the diabetologist. We have to tell her about the diet and everything. So the schedule of the visit we just discussed. Minimum 3 to 4 visits, but for those who have some comorbidities, they may need up to 7 visits. Immunization against tetanus, the WHO schedule, tetanus toxoid. This is at first contact or as early as possible during pregnancy, and the second dose is given 4 weeks after tetanus, third dose is 6 months after second dose, then 1 year after third dose, and 1 year after fourth dose, or during next pregnancy. The total 5 immunization against tetanus is being done. This is WHO recommendation. Now, what are high-risk pregnancies? Not every woman is high risk, but what are those high risks? That means these women are at more risk of developing complications during pregnancy or after the delivery. Women, young women having less than 18 years of age, or those women who are more than 35 years of age, short-statured women, grand multipara, that means women who has got more than 5 children. We have children, patient having 10 children, 11 children. That's quite common in our setup. Women delivering less than 2 years after the last confinement, that means short pregnancy interval. Women with history of complication in previous histories, such as she has history of pregnancy, or she has a history of obstructed labor in the last pregnancy, or hypertension or eclampsia. So you should always ask about the complication about the last pregnancy, whether she had uneventful pregnancy or she had any women with medical problems, which is discussed, women who develop complications during pregnancy, malpresentations such as presentation, transverse-like, compound presentation, and women with multiple pregnancies, that means twin pregnancy. Minor problems in pregnancy is vomiting and edema, that is why it can be easily dealt. Severe problems include anemia, that is less hemoglobin. WHO recommends hemoglobin less than 11 grams per deciliter is for less anemia. Moderate will be 7 to 10.9. Severe will be 4 to 7.9. So we have, and very severe is less than 4. Quite commonly, we have patients with hemoglobin of 6, 7, even 4. Commonest cause of anemia during pregnancy is iron deficiency anemia. So we have to take proper history from the patient if she's anemic. What can be the cause of anemia? In our setup, the most common cause may be excessive vomiting and diet. They do not take proper diet. And when they start pregnancy, they already have deficient ferritin stores. So what happens when the pregnancy starts? Pregnancy needs, during pregnancy, extra amount of iron is required. So what happens when they already have depleted stores? So they become anemic earlier. So as soon as you identify or by investigations or by clinical ground that she has anemia, you should always talk about the diet. What diet contains iron, such as you can talk about the green vegetable, you can talk about the kujur, you can talk about such a fruit such as apple, and then apple, cherries, which is whatever fruits are available. So you can tell them to eat, and like liver, they have got plenty carrots, they have got plenty of iron in it. Then you can prescribe the oral iron tablets. If they find that there is poor compliance or the patient cannot take it because of the gastritis, then you have to give her some parenteral, that means intramuscular form of iron. Or sometimes the patient is so severely anemic, 4 hemoglobin, 5 hemoglobin, and they have got symptoms, then you have to increase the blood by only ways the blood transfusion. Whenever you talk about the anemia, you should always think of thalassemia minor and sickle cell disease. Thalassemia minor is still common in our setup. That means you find if a primary gravid, you find she's anemic and she's primary gravid. So what can be the cause of anemia in that particular patient? So take proper history. If there's family history of thalassemia minor in the family. Any other bleeding disorders such as gum bleeding, petechial hemorrhage, or she has been bleeding from rectum due to hemorrhoids, or she had previously menorrhagia, should do ask why you have developed anemia so early in pregnancy, especially in the first pregnancy. And then look at the investigations, look at the absolute values. If you find there's some problem, or because iron deficiency anemia, thalassemia minor present with the same puerperal. Only MCHC is normal in cases of iron thalassemia minor. So if you suspect that she may be having any hemoglobinopathy, so you can go for electrophoresis. Bleeding in pregnancy before 22 weeks. If a woman has bleeding during pregnancy before 22 weeks, it is called as miscarriage or abortion, which can be either threatened, incomplete, inevitable, complete, missed, septic, and always exclude topic pregnancy whenever a woman is come with the bleeding. So these are the different types of miscarriages. That means if a woman is having only spotting and no pain, then it is not threatened. That means there is threat, although she's carrying on pregnancy, but there's threat she might born. Inhibitor means pain along with bleeding, and in that case, when you examine her, the horse is open, and you can feel the products of conception as well. That means not this pregnancy is not going to be saved, and she will definitely born. Incomplete means half of the products have been expelled out and half are still in the uterus. Complete means she has completely aborted. This means the whole of the fetus is inside the uterus, but there is no cardiac activity. Septic, when there is infection along with the abortion, or when they go to the eyes, or in those where there is unsafe abortion has been carried out, then that is septic abortion. After 22 weeks, but before the delivery of the fetus, if the woman presents with a bleeding, then it is called antepartum hemorrhage, maybe due to low-lying placenta, which is called placenta previa, maybe due to partial suppression of normal placenta, that means the site of the placenta is posterior and upper fundus. But if the patient, the placenta gets partially separated due to some reason, and the patient starts having bleeding, sometimes concealed or revealed, then it is called abruption placenta. If you exclude these two, and still she has bleeding, so always check for the first spectrum examination of cervix. Maybe she's bleeding from the cervix. Very rarely they may present with a cervical cancer, cervical erosion, or maybe polyp. So always, if you have excluded placenta previa and breastfeed, you should always think of any cervical lesion. Complication of antepartum hemorrhage. If a woman has been bleeding heavily, she can go into hypovolemia. She can go into irreversible shock. She can go into renal failure. She can have coagulation failure due to hypofibrogenemia and ruptured placenta, and even intrauterine death can occur. Hypertensive disorders, pregnancy again depends upon the grades of the blood pressure. Mild, the blood pressure is 140 millimeters systolic and diastolic is equal or more than 90 millimeters of mercury. Moderate, 140 to 160 systolic and 90 to 110 is diastolic, and severe is the blood pressure is greater than 160 millimeters of mercury and diastolic is more than 110. Sorry, there's a spelling mistake. 110 diastolic is again a severe hypertension. Complication of hypertension. This may the woman, if she has she's untreated or she's not taking any antihypertensive drugs such as we give in pregnancy, aldomet or MATERNAL, she may develop eclampsia, that is fits during pregnancy, and along with that, all systems may be involved. Maybe she may have cerebrovascular accident. Maybe she has cardiac failure, pulmonary edema, renal failure, or sometimes, and along with that, the baby may not grow. There may be intrauterine growth restriction and leading to death of the baby. So, complications of hypertension is not only for the mother, it is also for the baby. If the woman has constant high blood pressure and she has poor compliance on taking the tablet, the baby may not grow. The baby may become growth restricted and ultimately the baby may die. So whenever a woman has got hypertension, please do counsel them. Do tell her that they have to take this tablet regularly. What happens? They go to some other doctor or GPs and they say your blood pressure is controlled, so no need to take further blood pressure tablet. No, this should be explained to her. Until delivery, you have to take this tablets, and these women should be called more often for the antenatal checkup. Eclampsia is the tonic-clonic fits, convulsions, loss of consciousness, falling from the mouth. So women coming with tonic-clonic fits, many women, they come to our emergency, and when we take history, they have never had any antenatal checkup. Again, no primary care. They have not been to any hospital, but they have been going to guys who cannot check their blood pressure, who do not know how to examine them properly. So suddenly what happens, they fell down at home and then they have fed and they lose their consciousness and then they're brought to the hospital. The management of eclampsia is very important. As soon as the patient comes, turn her face to one side so that she does not inhale the vomiting. Airway should be put immediately. The fit should be controlled with magnesium sulfate. Diazepam is an old treatment, but where the facilities are not available, even diazepam can be given. But now in our setup, we have magnesium sulfate to halt the further convulsion fit. So this has been given in a proper dose. Along with that, we have to control her blood pressure. So our aim is to control her fit, to give her some antihypertensive drug and then ensure delivery. So in the antihypertensive drug, we've got hydrazine and MATERNAL available in the IV form. And if you think the patient is in a small setup, then she should be transferred or immediately transferred to her after giving the first aid. So a woman coming with first line of management state, and then you shift her to tertiary care center so that the delivery will be. Drug treatment pregnancy. So whatever drugs are given, you have to see whether the pregnancy is safe or not. They do not affect the fetus, because many times certain antibiotics are given by the drugs should only be given to women who do not affect the fetus. Medications for conditions for epilepsy, TB, diabetes, and hypertension should be continued after it is ensured that the drug does not have the therapeutic effect or does not change, or you can change. TB drugs can be given as before. Epileptic drugs try to reduce the dose, but a woman who has epilepsy, she should have preconception counseling so that if she's fit-free and the doctor has reduced the dose, then she should conceive, because some of these drugs may have some therapeutic effect. For the diabetes mellitus, we have glucophage, which is given easily. For hypertension, we switch over to either labetalol or Aldomet, which are seen during pregnancy. So it should be very important that women should be ensured that these drugs are not therapeutic, because many women who are diabetic will stop taking their drug as soon as they come to know they are pregnant, or who are epileptic will stop their drugs as soon as they know that they are pregnant. So please make them clear. Ideally, preconception counseling should be done for these patients with comorbidities, but again, these facilities may not be available for everyone, especially for uneducated women. They don't understand these things. Clean and safe delivery. Regular labor means when patients start developing regular painful uterine contraction at an interval of 5 minutes, accompanied by dilatation of cervix, that is the labor. Postpartum hemorrhage is after the delivery. If you find this loss of more than 500 ml or more bleeding, more blood from the vagina, so think this is postpartum hemorrhage. Now, how it's not possible to weigh it or to measure it. So the doctor who has been delivering the patient will be knowing that this is more bleeding as compared to normal. If a woman has heavy bleeding even within 24 hours, that is called primary PPH. And if the bleeding develops after 24 hours till 6 weeks, then it is called secondary PPH. If a woman has heavy bleeding, she may have complication of hypovolemia due to loss of blood, leading to shock and renal failure. Women at high risk of PPH are those who have got more multiparas, more than 4 deliveries, 6, 7 delivery, twin pregnancy, women with hydronias, coexistent morbid problem with the uterus, such as fibroid uterus, or she has been in prolonged labor. So that is the contract. Such in cervix and vagina, or genital tract infection. Problems during puerperium. So many women, they have breast engorgement, cracked nipples. So tell them, when you deliver them, tell them that you should have one visit after delivery to a doctor. And in case they do not want to come, they think everything is over, tell them in case you have any problem regarding breastfeeding, regarding bleeding, regarding stitches, please do come to the doctor. Cracked nipples can lead to, if they do not heal properly, or they may need sepsis as well. Puerperal sepsis means during the puerperium, that is following the delivery, and after 6 weeks, a woman develops fever, 99 or more than that, or she has constant pelvic pain, abnormal smelly vaginal discharge, or there is delay in the reduction in the size of the uterus, delay the contraction of the uterus, then think of sepsis. Complications of puerperal sepsis may be generalized peritonitis, may be pelvic peritonitis, they may come. Women, they do come with septicemia and bacterial shock. When we examine them, we find that there's a pus in the peritoneal cavity and there needs to be epileptotomy to be done. So whenever these women come with puerperal sepsis, try to find out the cause. Maybe she has breast engorgement, which has led to abscess, and she's running fever. Maybe she's having respiratory tract infection. Maybe she's having urinary tract infection. They drink less water. Maybe she has got foul smelling discharge. Maybe she's having peritonitis. So this cause should be found out by doing some investigation and of course ultrasound. Broad spectrum antibiotics are prescribed, and sometimes we will need to refer a patient to a tertiary care center if you find that the infection is extensive and she is not responding to broad spectrum antibiotics. Postnatal depression, yes, few women do have depression during pregnancy and after the delivery, and it is more common in the first week of delivery. The woman becomes irritable, mood swings, or crying episodes, and most of the time it is self-limiting. The counseling is very important. Support from the husband and family and even counseling of the woman is important, very important. Try to find out the cause. What is the reason? Either she thinks that now the baby is born and she may not be given attention, or either she's in pain or some other problem. So it is very important. And sometimes you need to give her some antidepressants as well after the delivery. This is called puerperal sepsis, psychosis. It occurs in 1 in 500 deliveries. The clinical features vary from slight disorientation to social withdrawal, self-negligence to infanticide or suicidal tendencies. That means sometimes they want to kill the child as well, or they want to kill themselves. That is a severe form. And this should be recognized promptly, and the counseling of the family and psychiatric referral and the need of antidepressants is required. Essential obstetric care comprises of sympathetic approach, that you should be very gentle and loving approach with the patient. Many patients, they have got so many problems. If you have few words of love, few words of sympathy can improve so many things. Try to detect serious problems on time, and properly treatment should be given. And if you think that the setup where the treatment is not available, the referral should be early with a proper referral note. Now, this was all about the Safe Motherhood. Basically, Safe Motherhood is a guideline, right? So 4 pillars we have talked about. These should be looked into it, and I think it is the duty of all doctors, it is the duty of all healthcare workers that this should be employed in some form. At least primary healthcare should be available for all pregnant women. Even if they do not come to hospital, at least someone can go to their houses, and then, like LHBs, they can go to their houses and give them at least some support in the form of some medicine or in the form of counseling and support. Another thing was I had to discuss is the MDGs. The MDGs, what is MDGs? These are the Millennium Development Goals. So there are 8 goals with measurable targets and clear deadlines for improving the lives of world's poorest people. So these are the MDGs. So how can we do that? To meet these goals and eradicate poverty, leaders of 189 countries, they signed the historic Millennium Declaration at the United Nations Millennium Summit, which was carried out in 2020. So the World MDG Summit was to eradicate extreme poverty and hunger, achieve universal primary education, promote gender equity and empower women, reduce child mortality, improve maternal health, combat HIV, AIDS, malaria, and other diseases, ensure environmental sustainability, and develop a global partnership for development. Now, these were the goals before the COVID had come. Now, the 4th and the 5th one was the Gynecology, that is reducing child mortality and improving the maternal health. So MDG had a focus on developing countries with funding coming from the rich countries. I'm not going into much details of MDGs, but basically these were the 8 targets which were given, which was signed by these countries. So those underdeveloped countries, they were given some targets that they have to improve these 8 goals. They have to carry out these 8 goals in their country by providing good health care or by providing some education, all this thing in their country. So, but where from where they will be able to do it? So the rich countries, they said the rich countries can provide them with some fundings or some funds as will be given by the WHO. They provide, WHO do provide us many things, like they are providing us with the contraception. Free contraceptives are available in our country. We have got family planning centers, and the woman is given free contraceptive devices, free contraceptive pills, intra-uterine devices. Even the permanent method of tubal ligation is done freely. So these fundings are being given to poor or underdeveloped countries, but it's not only there. We should also improve ourselves. We should improve, number one, the primary education needs to be increased. This is very important. The primary education, at least all person, all women, all children, whether they are male or female, should have primary education. So, and gender equity is not in our center. So these are the goals which you should know is the MDGs law. Again, after MDGs, SDGs have come, that is sustainable goals. I think that would be too much for you people. Only you should know about the MDGs. So this is more focusing on developing countries and funding from the rich countries. Thank you very much. So we can talk about any question. We can take some questions, and if you have any queries, we can talk about this. Saket?
जी मैडम,
क्वेश्चंस ले लेते हैं।
जी मैडम, मेरा देखिए चैट बॉक्स ओपन है, क्वेश्चन करेंगे तो आपको बताएं।
You talk about the tetanus toxoid. Yes, during pregnancy we have the women, they do get 2 shots, but ideally this the 5 shots should be given. Many women, they do have a small booklet, a card where they get all these shots, and you can advise it later on, like immunization for the baby. Immunization, this is the immunization for the woman. So if they cannot have 5 shots, she can have 2 shots in every pregnancy, 2 and 2, 4, and in the 3rd pregnancy she can have 1 shot. That will be 5 shots. Any other question? Single biggest issue is primary healthcare. Although clinics are being made up in every setup, but if you go to villages, you go to far off areas, the women will be coming to you and they say we don't have even a single doctor there. So the main problem in our health is primary healthcare. After education is primary healthcare, which makes small clinics set up in every area, especially far off areas. The problem is the doctors, they do not go to those areas. And even those doctors who come from villages, who come from these rural areas, they do not want to go back to their place. This is the main problem. So education, primary education and primary health care providing. This is the main issue. If they take 5 shots, then it is lifelong immunity. They do not need 5 shots of tetanus toxoid is given, that she does not need further tetanus toxoid. I hope you understood safe motherhood, right? It's very important, the 4 pillars of safe motherhood. What is PPD? puerperal psychosis, you will find that the woman, after the delivery, she behaves in a different way. She doesn't understand anything. She is hostile against the baby. Even she doesn't care about herself. There's change in the mood. There's change in everything. So a good doctor or a good doctor will definitely recognize psychosis. And these women are those women who also has previous history of some form of psychiatric illness. So that is very important that it should be identified. Otherwise, sometimes they may harm themselves, they may harm their baby. So as soon as we find that there is some abnormal change or there is abnormal behavior, to talk to the doctor, to visit a doctor, then it will be. Depression is mild form. Postpartum depression is a milder form. And that is usually self-resolving. The psychosis is something which is serious. That means that may lead to killing of herself, suicidal tendencies, killing the baby, making harm to the baby, making harm to herself. That will be psychosis. Mild depression, postpartum mild depression and antenatal depression occurs in quite a lot. And that settles down with the time, and care. If the family support is there. So, when many women do not have any family support, these are the women who goes into depression. Tetanus toxide is actually can be given to reproductive age women, but it is mainly tetanus toxides mainly for the pregnant women. These are for the pregnant women. It's not a universal immunization. It's not a universal. It doesn't come in the universal tetanus immunization. Psychosis, that depends upon patient's personality. If she has been having previous some problem, psychiatric problem or sort of any problem, so it may come immediately after the baby and maybe gradual deterioration of mental health. That we cannot say that whether it will be immediate or but usually soon after the delivery we start identifying that there is change in the behavior of the woman. So sometimes it can be immediate, it can be gradual as well. It also depends upon the personality of the patient as well. Any other question? Usually, we admit the patient for 12 to 12 hours. Normally, our normal setup where the normal delivery has been conducted without any complications such as no forceps delivery, no instrumental delivery. She can go home after 12 hours after passing urine once or twice after checking the bleeding. She can go. Many hospitals have the protocol of keeping women for 24 hours, but after 12 hours she can go home. Like in a civil hospital, we don't have place, so they do go within 8 hours, 6 to 8 hours, they do go home. No, not immediately. We do not discharge immediately after they come back from the labor, but within 6 hours we do discharge in civil hospital as we don't have place for these women. So, but in case they have got some where we think that they had difficult delivery or they had instrumental delivery, so we try to keep them more at least for 18 to 20 hours to 24 hours. We just want to exclude any hematoma formation and PPH. The PPH is immediate within 24 hours. The PPH is evident. Very few secondary women may come with secondary PPH. We do not keep them more than 6 to 7 hours. But for cesarean section, we discharge after 24 hours, so sometime after 48 hours.
Madam?
Incidents, actually, we always ask about the bleeding. Usually, washroom have you passed urine for the bleeding? It's not possible for the nurses or for the doctor to check for the pregnancy. Women think that she's having heavy bleeding, then normal. They do come or they are not discharged. If we think that they're like grand multi, a woman with having APS would not discharge, but in case sometimes they go home and they come back, very rarely. But before discharging them, we do ask for the bleeding, that if you have, what sort of bleeding you're having, have you passed urine? Because many women may not be going to washroom. So that can be a lead to uterine atony and pH. So it's very important that we ensure that she has passed urine and the bleeding on pad is normal, and then we discharge them. सही है? ठीक है, thank you. Thank you very much, all of you. Goodbye. Allah Hafiz.